Spinal deformity is a fairly substantial topic within spinal surgery, and this has developed quite a bit over the course of the last 10 or 15 years. Our understanding of it has also significantly improved. But generally speaking, there are conditions that are detected in the young and can be related to conditions such as congenital abnormalities or neurological pathology, and usually present with severe early spinal deformities. And then ones that have no identifiable pathology, which are quite common in the young, called adolescent idiopathic scoliosis or deformities. And then as we grow older, some of those childhood pathologies grow with us, and they continue to be de novo pathologies, while the commonest are ones in the adult patient that develop because of degeneration that happens over time and are called degenerative pathologies too. There's a small group of pathologies linked to trauma, which can cause significant spinal deformities too, but that's a very small proportion. For the most part, and I will focus here on the adult deformity pathologies, which are my area of expertise, some forms are asymptomatic. And the fundamental reason for this is that the spine is able to balance itself and put the head over the pelvis without the need for a substantial amount of utilization of muscle power. And for those, usually treatment for the most part is not required. There's another group which develops over time to cause the spine to be unable to support the head over the pelvis. So the patient would either tilt significantly sideways or forward. And for that reason, they start recruiting a substantial amount of force or power from their paraspinal muscles. And those conditions are painful and usually require treatment. Non-symptomatic spinal deformity requires no treatment. For the ones that are symptomatic, there's been a number of studies looking at the utilization of the strength and physiotherapy to improve the symptoms. Those have not been shown to be effective. However, they are worth trialing in the first instance before considering a much bigger or more invasive approach for the pathology. The natural history is that of a very slow progression over time, and that also has to be kept in mind when taking a decision to seek treatment. Not all patients require surgery, and certainly surgery can sometimes not be possible on some of the patients too, for a variety of reasons. However, symptomatic patients with pain that is labeled as fatigue pain after ambulation for some time, usually affecting the lower back with progressive forward or side tilt of the trunk or during the course of the day, tend to be candidates for a surgical intervention as long as the patient is physiologically able to tolerate this quite substantial surgical intervention and their bone quality is of good stock that allows for the utilization of instrumentation in the process. Spinal deformity corrections are high-risk procedures. Some would quantify the risk as high as 80%, most of which is minor complications. However, there's about a 25 to 30% risk of major complications with adult deformity corrective spinal surgery. And for that reason, it is the decision to go down that route has to be thought through very carefully. The surgery involves usually a fairly aggressive approach to the spine with instrumentation either through the tummy or through the back, and require a substantial stripping or exposure of the muscles over the spine, which can be painful and will require a substantial period of recovery afterwards. Because of the nature of the surgery and its aggressiveness, patients recover really slowly. Sometimes it takes them months to recover from it. With that being said, it doesn't mean that they have to be in bed for months. However, they won't feel themselves for months. So they will be able to walk shortly after. They'll be able to carry out their activities of daily living, but they will still feel quite tired for quite some time. And they will notice a significant loss in the ability to perform some functions they were previously able to do without trouble because of the extent of the fusion required in performing such procedures. So again, I emphasize that a decision to go down the route of deformity corrective procedures should be really thought through before one commits himself to having this procedure done.